So I'm going to be describing two popular systems for diagnosing and classifying mental disorders. And those are the Diagnostic and Statistical Manual of Mental Disorders, which is published by the American Psychiatric Association, and the International Classification of Diseases, the ICD, which is published by the World Health Organization. So the DSM was first published in 1952 and has had numerous revisions since then. We're now on the DSM-5, which isn't the fifth edition, but they arrive at it's the fifth major revision of the DSM. And so every few years or so, psychiatrists, psychologists, and other mental health professionals come together and study how we should describe symptoms of mental illness and how we should group mental illnesses together. The DSM doesn't tell us everything that we need to know about mental disorders, and we'll touch on that towards the end of this video. But it does provide a dictionary of psychological disorders. And I contrast that with the idea that some people say that the DSM is the Bible of psychological disorders. It's not the Bible. It doesn't tell us everything that we need to know. It doesn't provide divine guidance on how we should think about psychological disorders, but it does give us a common set of terms. It gives us a language that we can use so that when one clinician says major depressive disorder, another clinician knows what they mean. They know what symptoms they're talking about. They know what risk factors they're talking about. And so the DSM provides us with information about specific diagnostic criteria, specific symptoms that are required for a diagnosis. It tells us about prevalence, the percentage of the population that is thought to be affected by this disorder, risk factors, characteristics that may increase the risk of that disorder, as well as differential diagnosis, sets of disorders that are similar or have similar symptoms, and how to differentiate between those disorders, and then things related to comorbidity, so disorders that often go together. For example, we know that 41% of individuals with OCD also meet the criteria for a major depressive episode. And so having OCD is a risk factor for developing depression. And so you can access the DSM-5 by going to this link that is posted on Canvas as well as on this slide. And if you click on read this ebook, it will take you to this page here on the side where you can scroll through and see all the different ways that we currently classify and group together these symptoms of mental disorders. So for example, in the previous video, we talked about obsessive compulsive disorder. Here is what is listed in the DSM-5 regarding OCD. And this is just a snippet of what is there, just to capture the wealth of information that's found in the book. I have a copy of the DSM myself. It's quite a thick book. It's a pretty big book. And there's lots of information in there about prevalence, about risk factors, differential diagnosis, and things like that. As you can see here on the left, there are in the pink, there are specific diagnostic criteria. So there's rules about how to describe, how to specify the type of OCD that a person has. There's rules about how many symptoms that a person must meet in order for them to have the diagnosis, and various other recommendations for providing these diagnoses. By comparison, here is what is listed regarding OCD for the ICD, for the International Classification of Diseases. This is it. This is all that is listed. It's not very long at all. The ICD is more frequently used just for providing clinical diagnoses, particularly for billing purposes when you work in a hospital or in some other mental health facility where you have to input some kind of code in order for people to receive medical insurance. And so it's a very quick and dirty thing. The ICD also includes a broader range of medical diseases, everything from cancers to infectious diseases to all kinds of anything that can affect the body really is included in the ICD. And so the ICD is more useful for clinical practice, whereas the DSM is more valuable for research. What terms should we use to describe mental disorders? How should they be grouped together? So, some advantages of these two diagnostic systems, particularly focusing on the DSM-5, is that the DSM facilitates communication amongst mental health professionals, gives us a common language. It advances research and causes for treatments because we can do, when we say that we're doing a study on someone with a particular disorder, different researchers across the world are able to say, well, we want to study depression, we're going to use the DSM-5 criteria. And so anyone in our study who has depression, we make sure that they meet the criteria that are listed here, and that they're not they don't have some other symptoms that would conflate the results of our study. And it also allows people to bill for medical insurance and receive care. And that's a big barrier to care, is not being, if we didn't have this kind of language to be able to show insurers that this person has a real medical disorder known to be a psychiatric illness, then people would be barred from receiving care. Then there are some important disadvantages or limitations of these two diagnostic systems, once again, focusing on the DSM. One is that the number of disorders listed continues to increase over the years. So if you take a look at the first edition of the DSM, there are only 106 disorders that were listed in that edition. And now there are over the 347 different categories, as well as some other things in the later portions of the book that are additional causes or hypothetical disorders to be considered for future research. So the number of disorders is only going to increase over time. So it brings up some important questions. Do more mental disorders exist now than in the first edition of the DSM, which was published in 1952? Or have we discovered more disorders since then? Or do we simply know more about the biology of disorders since then? The best explanation for why we have seen this boom in disorders is that we have more words or more categories or more terms that we use to describe these psychological disorders, and that we've identified more subtypes of these disorders. The disorders that were grouped together in the first edition of the DSM, we've now separated out into different subtypes of different disorders. Another criticism of the DSM is that the symptom thresholds are arbitrary. So for example, here we have listed the main diagnostic criteria for major depressive disorder. For someone to classify as having a major depressive episode, they must have 5 or more of the following 9 symptoms for at least 2 weeks. And so what you see here is that this is a very useful way for us to communicate between professionals who has depression and who doesn't. But it brings up the question, why is it 5 out of 9? Why isn't it 4 out of 9? Why isn't it 6 out of 9? The decisions regarding where to put that threshold of how many symptoms they should be experiencing isn't fully supported by empirical research evidence. Also, you can have very different symptom presentations within the same disorder. So for example, someone could present with symptoms 1 through 5, and they would receive a diagnosis of major depressive disorder. Someone else could present with symptoms, 5 through 9, 5 other symptoms, and they would also have the same diagnosis, even though their symptom presentation is very, very different. A third criticism of the DSM is that it follows a categorical system rather than a dimensional system. So I'm going to use an analogy to explain this. For example, in any medical hospital, we're interested in knowing about people's blood pressure, as we previously described in last week's videos about stress, that blood pressure is a really important sign of physical and mental health. And so in most medical contexts, we're not just simply interested in, does someone have high blood pressure, yes or no, not just dichotomously. We're interested in how high your blood pressure is, right? Because if you're just above the threshold for high blood pressure, then that's useful information, but it's more useful to know if you are in an extreme crisis of high blood pressure, or if you're just past the threshold. We want to know the full spectrum or the full continuum or the full magnitude. And so any kind of studies or any kind of treatment that focuses on the full magnitude or full continuum, we call it a dimensional classification of a disorder, rather than a categorical classification, which is just you fit in this category or not. And that's very much how the DSM works. If you meet these 5 symptoms, if you have at least 5 out of the 9 symptoms of depression, you are in the depression category. If you don't, you're not in the depression category. And that's not fully the truth, right? If someone has, only 4 of those symptoms of depression, are they still depressed? Are they still experiencing distress? Like, can it still be affecting them in their real life, in their work, or in their relationships? Absolutely. So the DSM doesn't tell us that much about the broad continuum of symptoms, and also because we've grouped out and reclassified many of the disorders, the DSM doesn't tell us about the underlying constructs that make up these disorders. So, for example, anxiety disorders and depressive disorders are separated in the DSM. They are 2 different categories of disorders. When in reality, we know that many of the same personality characteristics that make people vulnerable to anxiety or depression and diagnosable disorders in those categories are the same, that it's the same underlying processes. In fact, many people would say that depression and anxiety really aren't that different, that it's the same negative feelings. Depression is oriented towards the past. I feel sad about something that is that has happened to me, or something that I've been through, or still going through. Whereas anxiety is negative feelings about the future. I feel anxious about, or I feel bad about something that's going to happen, or something I think is going to happen. So it's really the same underlying negative feelings. Or you can look at anxiety and obsessive compulsive disorders. We now have so many more words or so many more subtypes of OCD that we gave it its own category, when in reality, anxiety disorders and obsessive compulsive disorders share so much. It's the brain of someone who has a phobia or who has social anxiety completely different than someone who has anxiety and also engages in compulsions like an OCD? Probably not. Their brains are probably very, very similar. And so there are some major limitations of this view of the DSM and categorical classifications, and more researchers are moving towards dimensional classifications of mental disorders.